Hey everyone, this is Dr. Sophia Yen, and I want to welcome you to this live with myself, as well as Dr. Dona Kim Murphey, a neurologist, MD, PhD, and CEO, and founder of PrognosUs. She is a neurologist, a neuroscientist, because she's an MD, PhD, and we're born of immigrants, so always claim all your titles, otherwise your immigrant parents will be angry. And she's also been a community health worker, and she supports caregivers to 3 individuals with mild cognitive impairment and dementia within her family. She splits her time between Houston, Texas, and Seattle, Washington, so 2 very different politics of this country, with over 10,000 hours of community organizing experience at the intersections of race, immigration, poverty, and health. She also serves on the Area Planning Advisory Council of the Area Agency on Aging in Harris County, and brings experience providing diagnostic services in clinical trials and drug development for brain disorders to her work in family caregiving support for dementia. And I really love what she's building at PrognosUs to help caregivers and their families, but the caregivers, because it's very difficult. Her social impact company, PrognosUs.com, provides weekly live education and 24/7 access to facilitated care communities near you, virtual but place-based. So welcome, Dr. Murphey.
Thank you. I'm so glad to be here.
Yeah, let me do a quick intro of Pandia Health for anybody who is part of your audience and doesn't know us. Pandia Health, we are the only women-founded, women-led, the only doctor-founded, doctor-led, asynchronous telemedicine for the birth control pill pack ring and basic peri/menopause. And we also have a partner pharmacy that can deliver all of those medications to 49 states plus DC, and they take Medicaid in 9 and most private insurance except for Kaiser and TRICARE. And then our physicians can prescribe in 14 states, which covers about 70% of the US population. We picked the biggest states with the best bang. And we also encourage birth control and peri/menopause tourism. An example I give is we're not in New Jersey or Connecticut, but we are in New York. And who in New Jersey and Connecticut cannot get to New York once a year, put your foot in New York, or if you happen to be going through JFK or any of the airports in New York, then fill out the questionnaire and be like, I'm in New York right now, pay and be like, I'm in New York right now. And then our partner pharmacy can ship to 49 states plus DC. So that's a little bit about Pandia Health. I'm excited today that we are talking about, is this perimenopause/menopause brain fog, or is it dementia? Because so many of us that have a family history of dementia and are hitting this peri/menopause stage are just like, oh my gosh, is this the beginning of dementia? Is it too late? Have we gone too far? Is there anything I could do? Is it coming this early? Or is it peri/menopause/brain fog? And I think having a neurologist and a Menopause Society certified practitioner, but also an academic physician who just loves to check everything on openevidence.ai and just with reading as well, I think our audience is very lucky that we have all of these options today. So I'm going to ask you the first question. How do you tell the difference between the 2 things?
That is a great question. I think that the biggest distinction is that dementia is going to be functionally limiting, right? So it is going to ultimately impact your ability to live independently. It is something that is progressive over time. And in the simplest way, it is impacting memory, speech, reasoning, and behavior. In more advanced disease, you'll see it impacting physical functions as well. And in some of the dementias, actually, you'll see a little bit of that up front at the beginning of the disease. But it is something fundamentally that is not just like occasionally I'm having some problems with like the word being at the tip of my tongue or forgetting my keys, right? I gave this example today in speaking to some medical students about the difference between actually normal changes of cognition with age and dementia. which is a different question, right? So men can experience this as well, or women who are not menopausal or perimenopausal can still have this question, which is this just what happens with age, or is it dementia? This is the clearest example that I can give. And it is kind of, what is it? It's a story. So it's, not as clear cut in reality, but let me just try to provide the story, right? So you walk into a room and you intend to get a cup of coffee, like into the kitchen, right? You walk into the kitchen to get a cup of coffee, and as you walk in, you forget why you were there. You walk out of the room and you realize, it was a cup of coffee. I wanted a cup of coffee. Let me go get that cup of coffee. That is very different from walking into a room thinking, I don't know why I walked into this room, and then looking at the kitchen sink filled with dishes, deciding that you're going to go wash the dishes, and then midstream you get a telephone call, and you go take the telephone call, and for the next hour and a half the water is running and you're on that phone call, and then you get off that phone call and you walk out of the room with the water running and never having picked up your cup of coffee, right? That is very different. One of those situations is independence limiting, right? You can't live like that. The other is not. And so that's the best way I can illustrate the difference. The reality is that there is some overlap in the beginning because this is a progressive disease, right? So it will be the case that many of us will start off with very mild symptoms, and over a period of decades, right? Because we're preclinical often with some of these symptoms. We're like, oh, we have that word. We can't remember what it was, that happens to a lot of us in our 40s, right? And we might not ever discuss it with a physician. It's just something that we experience. That may, for a minority of us, progress to dementia. We don't know exactly for whom, right? We know that there are certain risk factors that certain people have that will put them on an accelerated path, and we can talk about those things. Women who are going through perimenopause and menopause and have those, modifiable risk factors, it will be really important for you to tackle those risk factors. It can be helpful to actually do the things which I'm sure you will share with us to address some of the symptoms of perimenopause and menopause, so that you can get, for instance, better quality sleep, right? Because that very, very importantly influences our cognitive skills. So yeah, I'll stop there for the time being.
Amazing. I think I see here a comment, and I don't know if you can answer this. Sandy Munger asks, I'm 71 and I want to know if my recall issues are age or menopause or both. And so, I feel part of it is menopause brain fog because I know it's there, and then like 30 minutes later it will come to me. Whereas I feel dementia, it won't come to you, or maybe it does. I don't know. Maybe you can't tell the difference based on a symptom.
Yeah, I think just one time point, it's really difficult to tell. When we think also about dementia staging, right? That is classically presented to patients and their families as this is a what's the word? Like oh my gosh, the word is escaping me now. It's a slowly
perimenopause brain in action before you guys.
Exactly.
Or is it dementia?
It's a slowly progressive disease. That's like a linear progression. That's how it's presented to us. But the reality is, if you zoom in on like a given day, right? Or a period of days, you may see fluctuation, right? In the way that we have good days and bad days as people who don't have dementia. The difference is that people who have dementia, they cannot mask as well. They cannot perform as well, right? So you're going to see that manifest a lot more obviously. And so then people wonder like, oh, there's just so much volatility. Like one day it seems like they're more advanced stage of dementia, and another day it seems like they're early stage of dementia. And that's just because you're too zoomed in, right? So if you step back for a moment and kind of look at what's happened over time, you will see over usually a period of years that people are declining. That should not happen with hormonal transitions of brain fog, of menopause. You will have some mild things that you struggle with in terms of your cognition, but it won't look like that. Yeah.
Yeah. No, I think now would be a good time to review, like you said, what are the, symptoms of peri/menopause and what's the definition of that? And so for people out there, know that perimenopause is like 4 to 5 years leading up to menopause. And menopause, by definition, is the 1-year anniversary of no periods. And so that period is like annoying. I call it limbo. I call it like nebulous, because you get a period and you're like hoping that you won't have one for 12 months. But then 3 months later, bleh, and you're like, oh, I got to restart the clock again. And then you wait and you see how far you can go. And then it hits you again, a little bit later, and you're like, oh, still got to wait for a year. And this goes on for 4 to 5 years. There's early perimenopause, which doesn't mean you get it early. It's just the early part of it. And then there's the late part of menopause and the early perimenopause. Early perimenopause is when your period starts to get irregular. So for some people, it could be like you used to be every 28 days and now it's every 35 days. It's like a plus or minus 7-day thing. Or 1 month is 28, 1 month is 35. Or now it's heavier than it used to be. You used to be a nice 3-day woman, and now you're a 5-day woman. And that's just indications that your hormones are getting weird. And so the way I like to think of it, that I was taught by my OB/GYN professor at UCSF, which I loved, is that estrogen is bricks and progesterone is the mortar. And so with the weird pew pew of the eggs coming out randomly during perimenopause, so perimenopause is chaos in the hormones, chaos in your ovaries popping out. And because of this popping out at weird times, that's what's making the period irregular. If it popped out every 28 days, you would bleed normally every 28 days. But now it's like pew, 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 pew. Like it's just doing a little crazy. And so when you stack 2 of them on top of each other, you have extra bricks. And then you got to lose the extra bricks. And so that's the heavy bleeding. And if you don't have enough progesterone to counteract the bricks, then you can get little bricks falling off, or you can have lots of bricks falling off. And so this is that whole, weird whackness of perimenopause, early perimenopause. And then late perimenopause is that the periods are spacing wider and wider apart. So now it's at least 60 days or more that it's spreading apart. And that's the late perimenopause. And so in early perimenopause, it's better to take over the system, flatten it out, and be like, you just be quiet. Stop doing your weirdness, and just, I'm a control freak. So I'm like, just be quiet. Let's just be stable on the birth control pill. And then when you get to that other part, where it's only happening every 3 months, every 6 months, or it's gone, then yes, put back the estrogen and progesterone. And the symptoms that would obviously, exacerbate dementia is, I love Dr. Kelly Casperson. She's a urogynecologist, and she says progesterone helps you fall asleep and estrogen helps you stay asleep. And so if you don't fall asleep, that's bad sleep. And everybody will now notice the 3 a.m. wake up. It's just crazy. Like all the women that hit this stage are like, yeah, you wake up at 2, 3 a.m. Yeah, I wake up at 2, 3 a.m. What is that? And then I can't go back to bed. And then can't going back to bed is insomnia. And so as you as a neurologist knows, if you have bad sleep, then it messes up your brain and fragments the healing, etc. And so it just is not a good situation for anyone. And then also there are hot flashes, which are during the day, night sweats. And I think night sweats, you can have like subclinical night sweats, which means you don't feel it, but it's happening and it's messing up your life. Your body's doing stuff when it should be sleeping, and it should be consolidating your memory and being happy. So I think those are probably the most disruptive things that menopause disrupting the brain. But also I think they've shown that with decreased estrogen, then the neurons change in the brain as well, right?
Yeah, I mean, with dementia, we know that there's definitely a hormonal component to it because there are many more women who have dementia than men. And it does not appear to be exclusively because women tend to outlive men, which is also true. So that, unfortunately, we have not invested in women's health in general. So we don't have as much literature on that. We have an understanding of dementia that was built on a particular body, yeah, in many dimensions, actually, not just gender or sex. So yeah, that it makes it difficult in this moment to know exactly like what are all the reasons for those disparities between women and men. But yeah, there is an effect of sex definitely on, and definitely hormonal effects on dementia, risk for dementia.
What lifestyle habits do you think may help support long-term brain health and reduce dementia risk?
Yeah, that's a great question. So, as I alluded to before, these are the things that we can control, right? And about 40% of cases of dementia are cases that can be prevented, or they can be substantially delayed in onset, or you can slow substantially the rate of decline once you have the disease. And once you have the disease in particular, it's important to be able to slow it down because you can preserve the greatest independent function for the longest period of time. So we aim to do that. And the way to tackle it is to really look at what the Lancet Neurology a couple of years ago in 2024 named as the 14 modifiable risk factors of dementia. And so there are lots of lifestyle habits that actually inform these things, including diet and exercise, staying away from toxins, certain kinds of toxins to the brain, being safe in terms of your brain, like, being intact. And there are other things like air pollution that can influence your risk for dementia. And so some of the things that those lifestyle habits directly impact are your chronic diseases that you may have, right? Like if your diet and exercise are poor, you're at greater risk for high blood pressure, high cholesterol, obesity, diabetes. All of those things increase your risk for dementia. The toxins that I spoke of are smoking and drinking. Actually, increasingly, we have found that really any amount of alcohol is actually not good for the brain, which is terrible to hear. I like to drink once in a while, but apparently it is not good for us at all, ever. So yeah, we really should limit or excise that from our lives, if possible. Things like education can also improve cognitive reserve. And that really is kind of the connectivity in the brain that allows you to sustain more loss of brain cells with dementia before anybody really notices. You will probably notice. Yeah. You will probably notice, but the more educated you are, the more languages that you speak, right? Like those things really help to preserve your ability to live independently in the world. And somebody who did not get as much education, right? And this is why it's important for us to have policies that allow everybody to have equitable access to education. If you didn't get as much education, then you have not built as much reserve. And so now you get a little bit of a hit and it's noticeable. Right? It makes a difference in terms of your ability to live independently. So that matters. The other ones are TBIs. So if you have injuries, you've had injuries to the head, if you played football as a kid and had a concussion, right? If you've gotten into a car accident, you weren't wearing your seatbelt, these kinds of things can also put you at increased risk. If you have hearing loss or vision loss, we think that's mediated by actually decreased ability to socially engage. If you can't hear what's going on or see what's going on, then you can't really be as involved and participate, right, in social interactions. Social isolation itself is an independent risk factor. So yeah, there are these 14 risk factors that we can influence. We can make different kinds of choices, right? And those things are not easy. It really takes, I think we have seen actually through clinical trials, it takes like accountability and structured support for people to be able to do that. It's hard. The world is not set up for us to not get chronic diseases. It's set up to do quite the opposite. We're sedentary, right? We eat a lot of processed foods. Yeah.
Yeah, no, it's, it is about being as healthy as possible, both for your function, but also for your mental function, right? So it's your physical and your mental, not just psychological, but literally your brain and your neurology functioning. I see that Ravid has asked a question: how much estrogen is too much for a woman in menopause? And what is the best balance between the patch and the progesterone pill? So I'll take that because that seems the Menopause Society certified practitioner question. Unfortunately, the current standard of care is to treat to your symptoms. And as a scientist, I don't like that. That's very subjective, right? Like, how sharp is my brain? And maybe you, Dr. Murphey, know of more objective testing measures, but even then I think it's a little rough, right? Like your serial sevens or like your testing. Like, I don't know if it differs by 1 point, 2 point, or if it's kind of like plus or minus 10 points. You know what I mean? The anal retentive in us can't stand a 10% difference because that's a B, and that's unacceptable in our harsh Asian tiger parent community. But all that to say that we don't treat to a number. We don't have the research for a number. But the danger of too much estrogen is that if you're stacking estrogen on top of estrogen, it can cause headaches, it can cause migraines, it could theoretically cause a stroke with the blood clot. The blood clot is more from the oral estrogen. So if you're on a transdermal or transvaginal estrogen, then don't worry about it. But if it's the oral because it goes through your liver, then it increases your blood clot stuff. And that's the too much estrogen. The other negative of too much estrogen is it's stimulating your uterus. So your uterus has a lining, and it's the estrogen, like I said, is little bricks. And you have to have enough progesterone to balance those bricks. If too many bricks, then that's endometrial hyperplasia, and that leads to uterine/endometrial cancer. So the best balance between the estrogen patch and the pill is not your symptoms, not a number, but really, like, if you are having breakthrough bleeding, then that tells us the estrogen has overtaken the progesterone's controlling factor. And that's why when you have breakthrough bleeding postmenopausal, we get scared because we as doctors are looking for endometrial cancer. And so we'll usually do an ultrasound. If it's too thick, then they'll do an endometrial biopsy, which is a different discussion altogether. But the crazy part for you all to know that we all need to work on is there's no numbing for endometrial biopsy. They can numb the cervix and they can go through, but when they do the bite, there's no numbing. And I'm like, would we go in a dude and bite his butt and be like, ha ha ha, you know, suck it up? No, we would numb it up and then we would do the bite. So I think we need to like instill some uterine lidocaine or do some local spray before we do this bite. Because women are like, just a pinch, says the doctor. And I get it as a doctor how removed we are, but like a couple of years ago, I skinned my knee, and you know, you see a kid skin that, just get up, suck it up, what's the problem? And I was like, oh, that hurts so bad. And I'm just crying tears. And I was like, oh, no empathy at all. So yes, have empathy for sampling people. Sorry about that little ADHD rant, but I hope that conveyed the estrogen, headaches, endometrial cancer if too much, and weird bleeding and painful breasts and migraines. And then and you need to balance it mainly to prevent endometrial cancer. Oh, let me see. The next question for you, Dr. Murphey. What memory changes would prompt a conversation with a healthcare provider? Like, what symptoms do you, if you see in yourself or you see in your beloved or someone in your family that you're like, time to see the neurologist or at least primary care doctor and do a standard what test?
Yeah, I think that, as I said before, it's going to be any progressive change of memory, speech, reasoning, or behavior. Those, I think, the fact that it progresses, and it's typically in dementia, it's going to be over a period of usually years, and it can be a journey that lasts decades in some cases. It's not going to be something that happens in days or weeks. That is often something that is acute and that might be reversible or treatable. So it's always important then to rule out all of those things. It might have been a recent medication change. It might have been a recent infection. It could be that you have a hormonal imbalance. It could be that you have electrolyte abnormalities or a vitamin deficiency. So there are a bunch of things that you want to make sure are not the cause. I will say that in most people where we suspect that it is dementia that explains cognitive impairment, it is not those things. It's a very small number of cases that it is those reversible things. But because they're treatable, we of course always want to ensure that those simple tests are done so that we can treat what is treatable. And it could be sometimes that those things are on top of an underlying dementia and, you know, treat what you can treat. The other thing is depression. Depression is, you know, we often have called it in medicine pseudo dementia, right? Because it can give you a clinical picture that is very similar. Somebody who is very apathetic, they can't remember things. findings. Yeah, they present in much the same way in older adults. So you want to be mindful of that also, and maybe try someone on an antidepressant, or get them plugged into cognitive behavioral therapy. And if you see improvement, then back to baseline, it's not dementia. But again, it might be something that happens with dementia, and it could actually be dementia, right? And not depression, in which case you'd want to rule out the depression first by treating it. So I think that the other thing, there are some things that are pretty definitively not going to happen unless, like, you're under the influence of a substance or something. You don't really lose autobiographical memory like early in dementia. So if you're starting to see in an older adult that they don't know where they are, or who they are, that's concerning. You shouldn't get lost in familiar places. That should never happen under normal circumstances. You should not forget how to use simple appliances that you've been using for a very long time. Once you start to have trouble with that, that's a bit more worrisome for a dementia. Those things may not overlap as much, but there is a lot of overlap in, like, the word at the tip of the tongue phenomenon, right? Forgetting your keys kind of thing. That happens both in normal aging, it happens in brain fog of perimenopause, menopause, and it happens at the beginning stages of dementia. So you can't completely disentangle these things. Really, when we have the benefit of a little bit of time, it's often that we can tell, okay, they have progressed over the last 6 to 12 months, and they're an older adult, and they have behavioral risk factors and maybe also heritable risk factors for this disease, then the level of suspicion is high, and it should be. Yeah.
No, I think the hard part is during, peri/menopause, you're losing your estrogen, and that definitely has some effect on the neurons. Just for people to know, the current state of research does not support going on HRT to prevent dementia. And so the two things that we can say is that they were afraid that the oral or transdermal estrogen would cause more blood clots into the brain, which is what they think may be contributing from HRT to dementia, because they noticed there was more dementia in people using HRT in some of the research. However, when they looked at it and separated it out, it was more the oral rather than the transdermal, and that the transdermal and oral, if it was started early, not greater than 10 years after that last menstrual period. So important for the audience to know that we now believe that there's the timing hypothesis, that if you're going to do HRT, you got to do it within 10 years of that last menstrual period. Otherwise, bad things happen. And just to explain the biology, for those of you who haven't heard me say this before, the way I look at it is at around 52, your body's like, thank you for your service, go out to pasture, and it takes away your estrogen, and then all sorts of bad stuff goes down. And so what happens on the blood vessel vascular stage, you no longer dilate your vessels as well. And so then they're skinnier and they can get blocked up. And that when you get a block, you can get a block in your heart, heart attack. You can get a block in your head, stroke. Or you get little blocks like showers of blood clots in your head, and maybe that's dementia. And so that's part of the menopause adding to that situation. The other thing is you take away the estrogen, and LDL, which is bad cholesterol, starts filling up your arteries. And so that is an increased risk of clot. And then you get insulin resistance, which puts you at risk for diabetes, but it also then causes triglycerides, which is another cholesterol, to shoot up in your arteries. So there's just all this blood clot stuff going down. And if you were to let that progress for 10 years, your artery, which was originally wide and had not so much stuff in it, has now accumulated 10 years of crack. And then you add oral estrogen, which then increases some blood clot situation, then you're going to have micro dementia clots, is kind of the thought that's going on. And so they recommend you definitely do not start HRT for brain health after 65 is what they're saying, or 10 years post your last menstrual period, roughly. And if you started early, and would be ideal. And transdermal is better than oral, at least for stroke and dementia, is what the current research says. I love that we've put up your company's website up there. Maybe you want to do an extra blurb on what you all do rather than me just reading the template.
Sure. So we provide access to care communities, which are virtual, but we attempt to organize by place and or kind of social concordance, which is like people who have the same care relationship as other people in the group. So maybe they're a caregiver who is taking care of a spouse. So spousal caregivers together, something like that. Mostly it's organized around geography or language also. So it's like, along what dimensions can we put people together where they really feel their experience is reflected in the experience of someone else, and they can really learn from one another and feel very supported in a true community. I think this is different from support groups in general, which are not so intentional. These are communities, and when they are geographically co-located, people often are wanting to do things offline together as well, and they do. It's really extraordinary, actually, some of the things that they do together to support one another. So yeah, we do that 24/7 support through WhatsApp, and we meet weekly for an hour with all of our care communities, and we have a different educational topic, and are also kind of semi-structured by design so people can bring their own things to the space every week.
Yeah. No, I love you have, is it a men's group or a husband's group?
A men's group, yes.
Yeah. No, I love the men's group, and I think there's a little potential, education for them, because or at least my family member, we educated them that when you take away estrogen, the vagina dries up. And when you have sex, then it's painful and it feels like ripping, and that will absolutely decrease your libido. But also with these changes in your hormones, they call it reverse puberty or cougarty. And so sometimes there's libido, but then if you have sex, there's pain. And then there's recurrent urinary tract infection, which you think is related to sex, but it's actually not related to the sex. It's related to the loss of estrogen causing the vagina to dry up, but the urethra is right above it. And so it too goes, and then it has more chance of urinary tract infection. And so letting people know with their partner, if they're choosing to have sexual relations, that vaginal estrogen twice a week will prevent recurrent urinary tract infections, will prevent urosepsis, which is when the urinary tract infection goes into the blood and could kill you if you don't catch it and give them antibiotics. But can also exacerbate dementia. I have a friend whose mom, that she just started acting weird, and then they found a urinary tract infection because they don't have the symptoms. It shows up in change of brain, right?
Yeah, no, absolutely. It's one of the most common reasons why people with dementia become acutely more confused or hallucinate. They are acutely different. And if for women, especially who already are anatomically predisposed, even without having gone through menopause. It actually did come up in our groups, in our caregiver groups, that, maybe you should consider, because somebody was having recurring UTIs that a caregiver was caring for. And another one of the caregivers mentioned, like, you should try vaginal estrogens.
Right. Yeah. So yes, everybody should know. Again, I believe it's Dr. Casperson, and she thinks anybody with a vagina 52 and above should just start throwing down vaginal estrogen. And for everybody that's listening, know that I personally saw it in patients starting at 60. So you don't necessarily have to start at 52, but maybe at 60. Or if you start having recurrent urinary tract infections and you haven't had them in a very long time, that's a sign. Right. Also know that when you go on systemic HRT, so if you do the pill or you do the patch or the stuff that goes everywhere, not just locally, that covers the vagina 50% of the time, but it doesn't cover it 50% of the time. So again, me, the scientist, is like, well, how wet is wet? Like, I don't want urinary tract infections, and I also don't want to fear painful sex. So hopefully, someday we'll have an objective measure. But currently we don't have an objective measure for what level estrogen we need to hit for certain things. Though I've heard the number 70 estradiol level for bone health. And it's like a U curve. If you go too far, then it doesn't do much for you, or a reverse U curve or something like that. I see. Yeah. Question. Are there other alternatives for our elderly mothers, aunts, sisters who can no longer take HRT due to breast cancer? So I love this question simply because it's the opportunity to educate about vaginal estrogen. So vaginal estrogen has been shown to be not systemically absorbed. So it's not enough of it to get sucked up into your boobs, into your blood and stuff like that, unless you're like smearing it all over. You're supposed to use it twice a week. But if you're using it every single day and smearing it all over, then there might be a problem. Though there are other people that have told me they've smeared it all over their skin and it's good for their skin and it has not increased their blood clots or other stuff like that. But for somebody with personal breast cancer, not a family history of breast cancer, and it was estrogen sensitive, because if it wasn't estrogen sensitive, then not relevant, you absolutely can have vaginal estrogen again because it's not absorbed systemically. But you cannot have the systemic estrogen, which would be a pill or the patch, or there's two types of vaginal rings. One is local, which is fine. And then there's one that's systemic, sperm ring, that breast cancer patient probably should not use. There's also two non-hormonal treatments for that are new and good, and they're called, do you know about the Candy neurons? It's new, and I didn't learn about it in medical school, but they regulate hot flashes. And one, there's both the name brands, and they're still horrible. One is Veoza and one is Linkuit. Veoza is the newer one, older one, and it requires that you check liver function tests. Linkuit does not, which is good, but it's more expensive. It's new, but what's cool is it's also good for sleep. So this one you get a twofer, and you don't have to do labs. But I don't know whether or not insurance will cover it. Other things you can use for hot flashes is paroxetine. There's actually a specific one for hot flashes. It's 7.5 milligrams, but as you can guess, because it's specific and it's on patent, they're going to charge you a heck of a lot of money. So a lot of physicians will just do 10 milligrams, which is generic and cheap, and they can do that. And then they've also shown that gabapentin is helpful with hot flashes. So all of these are non-hormonal options that they could use for hot flashes. And then for the vaginal, anyone can use vaginal estrogen. So let's see, what else do we want to cover here? I did want to cover the evidence-based information, or the largest myths about hormone replacement therapy. So along those lines about cancer, one way to test if your doctor knows that, whether they know the latest and greatest in menopause therapy, is, does estrogen HRT increase your risk of breast cancer? And if they say yes, they are not up to date on the latest and greatest. And so what that is the Women's Health Initiative in 2002 was one of the largest studies at the time, a randomized clinical trial, and they put them on conjugated equine estrogen. And if they had a uterus, they added medroxyprogesterone acetate. And so flaw number one was conjugated equine estrogen. We generally don't use that anymore. It's pregnant mare's urine. You take a pregnant horse and you take her pee and you take the estrogen and you go, here, have this, women. So it's not saying it's that bad, but that's what it is. And now we use bioidentical estrogen, FDA approved, FDA tested. You don't have to get compounded. You don't have to get pellets. You don't have to get troches, and God forbid pellets, never pellets. So that's that. And then medroxyprogesterone acetate is a very strong synthetic progesterone. And that one we no longer use for HRT. We now use bioidentical micronized progesterone. And there has been no increased risk of breast cancer from this one alone. However, the WHI was stopped because they're like, oh my gosh, people get breast cancer. And we have 10 and 20-year follow-up where they actually analyzed the group that only had estrogen because they didn't have a uterus. One of the top surgeries in those of us born with a uterus is take out the uterus when you're old because you no longer need babies. And there's fibroids and there's adenomyosis and there's endometriosis and there's crazy bleeding. So like, let's just take it out and then we don't have to deal with the fibroids and the adenomyosis kind of stuff. And so in this group was just the conjugated equine estrogen. Followed them for 10, 20 years of using this. And it was shown the group that only used conjugated equine estrogen had decreased breast cancer by 22%. And if they got breast cancer, decreased risk of death from breast cancer by 44%. So now we believe in general, estrogen does not increase your risk of breast cancer, at least HRT in this form. And then we think it's the progestin. And there's more research showing that the synthetic progesterone increases your risk. But know that it increases your risk by 8 out of 10,000. And so the way I think of it is 9,992 people benefit and 8 people benefit, but they also got breast cancer. The good news is we are now very good at treating and detecting breast cancer. So as long as you get your mammograms, ladies, and the follow-up, if you have dense breasts, whatever is follow-up needed for that, then we catch it early, we take care of it. Few people die from it. I agree it sucks to have chemo, it sucks to have a mastectomy, but it's not dead. So no, that's the number one myth, and that's one way to test if your doctor knows the latest and greatest. There's a follow-up on the vaginal estrogen. Absolutely recommend vaginal estrogen forever until you die. So the second question to ask a physician to see if they know the latest and greatest is, how long should I be on HRT? And if they come up with 10 years, or they come up with until 65, then and The reason why is, if I give you estrogen to prevent all this bad stuff, the bone density loss, the possible brain stuff, definitely the heart stuff, and other stuff as well, and then 10 years later I take it away, what's going to happen? All the bad that would have happened here is going to happen here, unless all of a sudden your body manifests estrogen. And your body's not just, your ovaries are gone. The thing that gave you estrogen is out. We ran out of eggs. You need the eggs popping and situation to make that. It's gone. People are working on an artificial ovary, FYI, but we don't have it yet. And so if you talk to any Menopause Society certified practitioner, they're like, you're going to find this menopause patch on my dead body, unless I manifest estrogen. And then vaginal estrogen, as I mentioned, no risk of breast cancer whatsoever with vaginal estrogen. The contraindication for vaginal estrogen is a cancer in your vagina that is estrogen sensitive. So if that's the case, then definitely don't do it, but can use it until your last breath. So sorry if I explained poorly and that was confusing. Okay. I think we covered that. And so what kind of tests are done for dementia? Like, what's first line in your doctor's office? And then do you see a neurologist, or do you see a neuropsychiatrist?
Yeah, so most commonly, like bedside or in the doctor's office, and that doctor is often a neurologist, can be a psychiatrist, a geriatrician who's internal medicine trained. The dementia diagnosis can technically be made by your primary care physician. It just isn't often done by that person because I think they're overwhelmed with too many things to do, and they don't necessarily feel comfortable with delivering the diagnosis in a disease with no cure, where social care is so important and all of the resources that they don't necessarily know about. They need really an interdisciplinary team to support. Not everybody feels equipped to do that. And so they might send you to a specialist to get a formal diagnosis. The tests that they often do in the office are mini mental status exam, or an MMSE, or the Montreal Cognitive Assessment, or a MoCA. Neurologists tend to prefer MoCAs for whatever reason, but both are validated tools, clinical tools to follow cognitive function. In perimenopause, menopause, the brain fog that is associated should not reveal any disturbances on those cognitive tests. They are often just subjective, which is not to say that they're not real and they're not important, but they are subjectively experienced, but they're not often documented in a way that demonstrates that you have any kind of cognitive impairment, actually. So yeah, those are the tests that we typically use.
Nice. So just personal random thought is having a hard time like memorizing numbers. Do you know what I mean? Like, now every single time they want secondary authentication, it's like 6 or 7 numbers, and like not being able to remember that is probably not normal. Right?
I mean, I guess it depends on where you started, right? I think that's called the digit span. I think it's like, what is your digit span? Yeah. I mean, it depends on where you started. Again, that's an important thing when you think about a neurodegenerative or progressive cognitive disorder, right? It's where did you start? and where are you now? But yeah, I mean, you definitely could have problems with that amongst the many other subjective concerns that we have. That can be a part of normal aging. It could be something that we experience with brain fog of perimenopause or menopause. That, again, unless it is progressively worsening and there are then more symptoms as time progresses, we wouldn't be super concerned about. Yeah.
A lot of people are talking ApoE4, and what is the risk of dementia with ApoE4 one copy versus two copies? And like, is it like a 80-90% you're gonna have dementia, or is it like a relative risk, like you have a 2 times greater risk and the current risk is 5% and now it's 10%, or is it like from 50 to 75? What is the reality of an ApoE?
Yeah, if I recall correctly, I haven't looked at this in a while. It's 4x and 8x, depending on if you have one or both alleles. People often ask me about this particular genetic test, but genetic testing in general, and also now with the blood biomarker tests that are available for Alzheimer's disease specifically also, they ask whether it is worthwhile to do those tests. And my answer is always, will it make a difference in how committed you are to tackling the modifiable risk factors? Some people have to be told that they have some enormous risk that is inherited, right, before they will take any definitive action on the things they can control. Other people don't have to be told, right? I can see in my family, I have 6 first and second degree relatives with dementia. I know that I have a high heritable risk of dementia. I do not need to do the ApoE4 test to tell me that. I am very committed to tackling those modifiable risk factors. But if you do need something objective to tell you, yes, to motivate you, then by all means, do that. So yeah.
And what is the difference between Alzheimer's and dementia?
Alzheimer's is the most common kind of dementia. So dementia is kind of an umbrella category. Alzheimer's impacts about 60 to 70% of all people who have dementia of some kind. The other very common ones are vascular dementia, Lewy body dementia, and frontotemporal dementia. They don't all present actually with memory being the primary problem. Some of them are behavioral changes or speech changes. There can be a motor component, like in Lewy body dementia, where you have Parkinsonism, like a tremor on one side. So yeah, they can be a little bit different in how they present as they progress. So this is the loss of brain cells, regardless of which kind of dementia it is. That is fundamental to it being a dementia, that you're losing brain cells over time. Everybody starts to look similar, right, as you get to moderate and severe disease. But it helps to kind of know in the beginning, I think, for the purpose of knowing what this will look like, especially in the beginning, because it can look quite different. And also feeling more connected to community, because there are support groups that are really organized around disease. So like the Association for FTD, for instance, or the Alzheimer's Association, right? So you might find your people in those communities, and yeah, that can be helpful to know then.
So for Alzheimer's, do you have to like do an MRI, or there's now these blood biomarkers that are good enough? Or I heard you can only diagnose it on autopsy when you go in and you find plaques. I don't know. Or some people say plaques is an association and not a causation, right? Thank you, Christy, for joining us.
Yes, thank you so much. Great to have you here. Yes, so the blood biomarkers can be very helpful if a person already has symptoms that are highly suggestive of the disease. When people see that their loved one has this disease and then they want to do the blood biomarker testing, that is very much an open question of like what information that is providing you when you are asymptomatic. So really, we want to use those when we have symptoms. Otherwise, it's questionable what information it actually provides. And it might make you unnecessarily concerned about something that might not happen. And again, it's about risk, right? It's not necessarily telling you unless you have the symptoms. So yeah, it's again something that you can't necessarily control. So you can control what you can control, which are those 14 modifiable risk factors of disease, and that's a lot of space to actually have some agency. Yeah.
Can you, again, remind me, what again are the 14 modifiable risk factors?
Yes, I can actually drop it. Should I drop it in the chat here?
Yeah, you could probably dropping it in the comments would be great. Yes.
Okay.
And
Yeah.
anybody.
Here, I can put this here.
And then we'll read it out loud. So it'll be on video too. And then someone asks, this is a very good question. If your mother is diagnosed with dementia, does it mean you most likely will get it as well? Is that like a 50% or a 25% or a what percent do you think?
So that is not entirely clear. What we know is that when you have a first degree relative who's impacted, so your mother or maybe your child, if you're that unfortunate, I guess, that it presents in your child before it presents in you, a first degree relative is going to put you at greater risk than a second degree relative or a more distant relative. So we do know that to be the case. Again, we're talking about heritable risk, which we can't control. So, does it really matter? Maybe it matters, because if you know that you're at high risk, then you're going to be more motivated to take care of the things that you can take care of. But yeah, so I think it's more useful to think about it in that way. If I have 3 first degree relatives, that puts you at, significantly increased risk. But there are still so many things you can do with those modifiable risk factors to actually never develop the disease, or to develop it so late in life that you still end up living a high quality, mostly independent life until the end, right? Like, that's the hope. Where I sometimes say, for educational purposes, right, to kind of really understand this, if we live to be 200, we would all have dementia. The strongest factor for dementia is in fact aging, which none of us can control. We will all get older, hopefully. So yeah, we can't control that. But some of us are on a more accelerated path, and that is defined by some of these choices that we make in large part.
What are you doing with respect to physical activity, or how much physical activity would you generally advise someone to do?
Yeah, I mean, we're supposed to aim for 150 minutes of moderate exercise a week, right? That's kind of the public health evidence-informed recommendation. So you're supposed to get your heart up to that, heart rate, target heart rate or whatever. You can do that from just kind of vigorous walking if you wanted to do it that way, or in a lot of different kinds of exercises. I really do try to hit that. There have been a lot of studies recently about steps, how many steps you take. A lot of us, I think, we're trying to hit 10,000 steps a day. And then there was a study that said, actually, you kind of plateau at 7,500 in terms of cardiovascular benefit. So I was like, great, less steps. Also, I think they're finding that the more sedentary you are, the worse it is for your cardiovascular health, which includes your brain and your risk for dementia, right? So, not sitting all day, but maybe every hour getting up and walking around for 5 to 10 minutes briskly, that can help to reduce, the cardiovascular risk for the disease. There's a lot of overlap, by the way, between Alzheimer's dementia and vascular dementia, both clinically and also pathophysiologically.
Yeah. So it looks like, how much is too much drinking? And does that also include smoking and or eating marijuana?
That's a great question. I don't know the answer to the question of edible marijuana. Smoking, the recommendation is to not smoke at all. If you are smoking, then it is to quit smoking. So it's not a matter of recommending just smoke less. They don't want you to smoke at all. And drinking, it used to be the case that and in fact, there were some studies that talked about the benefits, the cognitive benefits of red wine. I don't know if you remember some of these studies.
Yes. No, that was a very popular thing. And now we know alcohol causes all the cancer and all that stuff, right?
Yeah. Lately, it is really that there is no minimum. It's all bad. So, I mean, the way I think about it is lots of things that we do in life are not necessarily the best for our health. If we do them once in a while and it brings us a tremendous amount of joy, it's maybe part of our culture, right? That we do it, or it's family custom that we're engaged in that kind of activity, eating that kind of food, whatever. Maybe that's worth it. It's a trade-off, right? But yeah, technically we should not be doing any of those things. Yeah, if we want to have the maximum brain health for the longest period of time.
Yes. And I just did a quick Google, and it says for marijuana, Stanford University School of Medicine found that THC, so the psychoactive component in marijuana, so whether you eat it or you smoke it, causes direct inflammation in the endothelial cells in your blood vessels. So it's all about micro blood clots, as we kind of spoke about earlier. And this inflammation can then cause atherosclerosis, which is the narrowing and hardening of the arteries. Inhaling marijuana has a spike in your heart rate. So that's a physical stress on your arteries, and a higher blood pressure causes increased shear risk. And then marijuana can also cause reversible arterial vasospasms, which is like cramps in the arteries, which are like micro bursts of lack of oxygen to places that you want. But it's obviously smoking is worse than eating it is what the conclusion. But also the eating it, shockingly enough, has an effect. I'm curious if CBD, which is a more calming effect, doesn't have. The THC, it says, definitely has kind of an effect there. So that was our fun.
I learned something. Thank you for asking the question, Susanna.
Yes, this is a great question. And then for me, like moderate activity example is brisk walking, 2.5 miles per hour or faster, water aerobics, bicycling slower than 10 miles per hour on flat ground. So you don't have to go faster than 10 miles an hour. Doubles tennis, which I get is less strenuous than singles tennis, where it's all you. And then a fun one is ballroom dancing.
Oh, I love it.
And then
I love it. Actually, special thing about dancing. There was a study, I think it was of Latinos who were doing, I guess, Latin dance. I think this is in Chicago. And it really does, it did show a cognitive benefit. I mean, this is like all good things at once, right? It's like movement. So it's like cardiovascular exercise, it's exercise, and it is socialization, right? Yes. It's great. I think dancing is a great way. If you enjoy that, please.
Yeah. No, I always loved square dancing in school. My daughter has taken ballroom dancing, and she says it has really helped her. It's actually a social ballroom dancing, and it has helped her social skills, taught her to make small talk as you switch partner to partner, to partner. So
yeah, no, it's so great. It's the one thing that I can do where I can't perseverate on whatever it is that I want to be thinking about, because if you're doing it right, you're really trying to read your partner and be responsive on the dance floor and to remember the steps also.
Yeah.
So it's too much. It's too, if you're really in it, trying to do it well, you can't really focus on anything else, which is great. It's a good respite, I think, from
stress reduction too. Yeah, we just need to do more of it. Though I think the men are very resistant. It's a sexist thing. I'm sure there are men that love it, but my good friend actually loves it, and I think maybe found his current wife that way. He's a total salsa dancer, so he will have a great brain and body forever. Yay, Shoe John! Shout out for Shoe John. I see you see the question.
Yes. Can you slow down dementia? Yes, you can. Those are those 14 modifiable risk factors. Actually, I dropped the link, but was it visible? I think it looked really weird.
No, it was ugly. So I will read it out loud from what I did on the Google search. I'm sure it's the 14.
This is also a short version.
Education, hearing loss, high LDL. So like we talked about, HRT helps with that if your LDL shoots up because you lost estrogen, but certainly don't be afraid of statins. The joke is anybody who wants to live to 100 is on a statin. Or the better thing is now that injection anti-cholesterol drug, but crazy expensive, an injection. Depression, traumatic brain injury, as you mentioned. That's why as a pediatrician, I don't recommend football. I do not recommend boxing, and all these boys on scooters with their helmets, like good, but still could bonk your head and do all sorts of crazy things. But really the boxing and the football, if any of you have seen the movie Concussion with Will Smith, I don't even know how we have that as a sport. And then physical inactivity, sitting down, they're saying is the new smoking, right? In my life, we do telemedicine, and I spend 8 to 12 hours a day in front of my computer doing social media, doing email, doing blah, blah, blah. And that is equivalent to smoking. So my advice to people, just for funsies, everybody that's still listening, is you can bounce in your chair on your Zoom calls. This is a normal chair, it's just a little bouncy. And then yoga ball, I tell my patients, because the biggest muscles in our body are our quads and our glutes. And so if we move the biggest muscles in our body, then just 10 minutes out of every hour, if you're like 3 to 9 o'clock, my kid's doing her homework because, junior year, senior year in high school is intense. That's 60 minutes, right? 10 minutes out of every hour for 6 hours. Or you binge. I am such a binger. It's so bad. 3 to 5 hours of Netflix. Anything above 2 hours has to be done on a yoga ball or bouncing on the bed or mini sit-ups or mini leg lifts or one leg lift, just like while you're binging your 5 hours, then it doesn't count if you're moving. Diabetes. So don't get diabetes by 1, not having estrogen and having insulin resistance, but 2, obesity, overweight. And if it's in your family gene, it is what it is. Take the drug to make your sugars good, because the sugar infects the arteries and causes these clots. Smoking, we talked about. High blood pressure. If you're just predisposed to it, take your drugs. If you can, and you're salt sensitive, then cut your salt. And obesity, we've talked about it. I'm an obesity specialist. If you qualify for GLP-1 and somebody will pay for it, do it. That's what I would say. It's pretty impressive. But also do the lifestyle change to support that weight loss. And I actually believe everyone should be able to come off a GLP-1 if they make the lifestyle change to fit their new weight. But they might also need a touch of metformin. And for all you out there, metformin is what we used to use before we had GLP-1s, and it helps people maintain their weight. So, and I also personally think in menopause, our metabolism is a little different. So I just pop a metformin every now and then, 500 milligrams twice a day. Or if I particularly have a whole bunch of carbs that day. Alcohol consumption. It says excessive alcohol consumption, as you and I discussed. There's many people that have said 0 alcohol is what it should be. And again, for people who freak out that, oh my God, HRT increases my chance of breast cancer. Drinking 3 glasses of wine is a far greater risk of breast cancer than HRT. So if you want to do comparative, lose that 3 glasses of wine. Find a different stress relief, such as dancing or other things. Vision loss, like you said, it doesn't have hearing, but I agree with you. The two should go together because you're not getting that input and that sensory. Cataracts that you may not know is happening in your old people. They may not express it. Make sure they get an eye check, and cataracts happen. Social isolation. That's why men do not as well as female. Women are gregarious. They talk. We have our girl chatty thing. Dudes are lonely and sad. It's just, again, sexist stereotypes, but kind of old. And then air pollution, but I guess, I don't know what you can do about that other than an air cleaner and KN95 if you live in a bad area.
And, be civically active. Vote for the right people,
Yeah.
right? Who are going to make your air quality cleaner. Yeah, that doubles your risk of heart attacks and strokes and dementia also. Yeah.
Well, as you know, I run Chatty and we ran over. So where can people find you? Where can people find PrognosUs?
Yeah, you can find us at PrognosUs.com. That's Prognosis spelled with a US for like us together, reflecting like our commitment to care communities that we co-create with you all as caregivers. If you go there, you can send me a message through the contact form if you have any questions, if we can get you plugged into any of our care communities. We have a lot of free resources on the website too that you can sign up for. We have a 40-page beginner's guide to dementia for people who are kind of new on this journey, and a free newsletter as well. So go sign up. Yeah.
Thank you so much for everyone who attended. And thank you, Dr. Murphey, for being here. It's amazing to have an MD, PhD, but also community activist, a caregiver for 3 or supporting 3 caregivers. I know I'm doing it too, but only 1, and it's very stressful. And yes, this is recorded. We will post it on YouTube. We will also post clips on our various social media. So follow us at Pandia Health. Pan is every, Dia is day, because inevitably spell correct, we'll try to make it Panda Health or something like that. And then we also have Pandia Menopause. And then I'm building my Instagram and TikTok. So that's Dr. Dr. Sophia, Sophiaen, on Instagram and TikTok. And these are all our socials that we put up there. So again, thank you, Dr. Murphey, for your time and expertise. It's been a pleasure. And your work. I really think what you're building is so necessary. Caregivers have been shown to have like a double mortality or 50% decrease in lifespan just by being a caregiver, from, I think, the mental and the physical strain, but more the mental of being a caregiver.
Yeah, absolutely. Yeah, it's very heavy, the work. Yeah. Thank you so much also. It was a pleasure.
Yes. All right.
Bye, everyone.
Bye.